Assalamualaikum warahmatullahi wabarakatuh. I'm Dr. Amal, together with Dr. Tantri from Anatomical Pathology Department, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital. Today, I would like to present introductory lecture for anatomical pathology practice in reproductive module. The topic is disorders of the female reproductive organ. Please ensure that you already have read the laboratory work guidebook beforehand. In this lab work, we will have 6 topics. The first one is acute chorioamnionitis, and then we will have Hydatidiform mole, and then ectopic pregnancy, and the fourth is female genital tuberculosis, and then we will have endometrial polyp, and the last one is Galactocele of the breast. Let us begin with the first topic, acute chorioamnionitis. Infection or inflammation of umbilical cord occurs through two main routes, ascending infection and hematogenous or transplacental infection. Between these two routes, ascending infection is the most commonly found. It is mainly caused by premature rupture of membrane. In premature rupture of membrane, the non-intact amniotic membrane would weaken blood placental barrier function so that bacteria can easily enter the amniotic fluid. The presence of bacteria in the amniotic fluid will elicit immune response, neutrophils in this case. Neutrophils that have extravasated from decidual blood vessels would move upward through the decidua to the chorion to the amnion and at the end reach the amniotic fluid. Placental infection or inflammation may be manifested in the umbilical cord also. As we can see here, the darker cords means that inflammation has involved not just one vessels but many vessels. The two umbilical arteries and one umbilical vein. In this case, we can observe the neutrophil filtration surrounding the wall of the arteries and the wall of the vein. According to the term, acute chorioamnionitis means an acute inflammation of chorioamniotic membrane, while acute pneumonitis means an acute inflammation of umbilical cord's wall. Pathologists would assess the stage of placental inflammation based on the distance neutrophils taken from the decidual blood vessels to the upper layers. The farther they travel, the higher the inflammation stage would be. In pneumonitis, we have to assess the number of blood vessels affected by inflammation. At the beginning, the inflammation found in the umbilical veins wall, and afterwards, it expands to the arteries wall. It means that when we observe inflammation in umbilical arteries wall, the pneumonitis is high stage. Inflammatory response in chorioamniotic membrane is known as maternal inflammatory response, while the inflammatory response in umbilical cord tissue is known as fetal inflammatory response. These are target organs of chorioamnionitis, especially in the cases that have elicited fetal inflammatory response. Many organs may be affected, such as heart, lungs, and kidney. This is the microscopic appearance of chorioamnionitis. As we learned before, we have to assess the maternal inflammatory response in chorioamniotic membrane. Here is the membrane roll. We can observe the decidua on the right side, and then the chorion and the amnion with its surface epithelium on the left side. The chorionic wall here looks edematous and contain multiple dots everywhere. In higher magnification here, we can see that the dots actually are the acute inflammatory cells, the neutrophils. They are scattered from decidua to the connective tissue of chorion and amnion, and moreover, they have infiltrated the surface epithelium of amniotic membrane here. In this picture, we can see that some of amniotic membrane epithelium are destructed by the inflammation, and some of neutrophils have been degenerated, becoming necrotic debris. In this microscopic specimen, we can assess the fetal inflammatory response from the umbilical cord. There are two pieces of umbilical cord tissue in our slide of this lab work. The first one, the one near the membrane roll, doesn't contain inflammatory cells, while the other one located away from the membrane roll is the one with acute inflammation. You can compare between these two cord tissue, the normal and the abnormal ones. Here we can observe another multiple dots surrounding blood vessels wall. These dots actually are the acute inflammatory cells. In the higher magnification here, we can see the neutrophils that originally located in the lumen of blood vessels have crept up to the vessel's wall. It shows that the fetal inflammatory response have been elicited. In this picture, we can see neutrophils in the umbilical cord vessel wall. Now we move to the second topic of our lab work, Hydatidiform mole. Hydatidiform mole is gestational trophoblastic disease. It's caused by abnormal fertilization. There are three types of Hydatidiform mole: the partial mole, the complete mole, and invasive mole. In clinical setting, how do we recognize molar pregnancy? The size of the uterus might be large for gestational age. The serum HCG level is highly elevated, more than in normal pregnancy, so that clinically the patient tends to complain about hyperemesis. We also might find spontaneous bleeding or abortion. In some cases, the patient passes the mole vesicles through vagina. For the prognosis, complete mole usually have more unfavorable outcomes compared to the partial mole. They have the higher risk to be invasive mole, where the moles invading uterine wall, not stays in uterine cavity anymore, or even progress to malignancy, choriocarcinoma in this case, and they are more prone to have recurrent molar pregnancy. This is an ultrasound view of pelvis. Hydatidiform mole would give the snowstorm appearance, where we can spot scattered cystic hypoechoic area within the uterine cavity. This is the microscopic specimen of Hydatidiform mole. Here we can see the uterus. The uterine cavity is filled with vesicles, medium to large size, up to about 1 centimeter per vesicle. They differ from the villi normal pregnancy, which is uniformly small. Here is the microscopic specimen of our lab work. It is composed of fluid-filled large vesicles with thin, translucent membrane. Looks like cystic grape-like structure. In this microscopic specimen, we can observe larger than normal chorionic villi with edematostroma, and there are proliferative trophoblastic cells surrounding the villi. In this picture, we can see the hydropic changes of villi forming a cistern. Cistern formation is caused by severe hydropic change that push the stromal connective tissue to the edge. This is another picture of hydropic villi with cistern. Here are the cisterns. We can also observe the proliferation of trophoblastic cells. These are the trophoblastic cells that are proliferative. Once again, this is the cistern, and this is the normal connective tissue that push to the edge of chorionic villi. Here is the cistern, while the stroma is pushed to the margin. Look at the proliferative trophoblastic cells. Normally, in first trimester of pregnancy, the trophoblastic cells on the surface of chorionic villi consist of only 2 layers of cells. The inner one is cytotrophoblast, while the outer one is syncytiotrophoblast. This is the picture of proliferative trophoblastic cells, especially the syncytiotrophoblast. You may refer to histological picture to differentiate between cytotrophoblast and syncytiotrophoblast. This is the higher magnification of trophoblastic cells. Now we move to our third topic, the ectopic pregnancy. Ectopic pregnancy is a condition where fetal implantation occurs outside its normal place in the uterine cavity. About 90% of cases of ectopic pregnancy occur in the tube, but it can also occur in the ovary, in the abdominal cavity, and other organs. 90% cases of ectopic pregnancy occurs in the tube. Why? It is because most of fertilization occurs in the ampulla of fallopian tube. This is related to the main risk factor of ectopic pregnancy, that is, chronic salpingitis. Chronic inflammation of the tube, usually leaving a scar in the lumen. This scar would avoid the fertilized egg to move to the uterine cavity and implant it within endometrium. This is the reason why most of ectopic pregnancy found in the fallopian tube. Would ectopic pregnancy be dangerous? The fallopian tube is not the designed place for developing fetus because its muscular wall is so thin compared to the uterine wall. Smooth muscle cells in uterine myometrium would undergo hypertrophy and hyperplasia during pregnancy, while the smooth muscles in fallopian tubes are unable to undergo such adaptation. At some point, the tube's wall would rupture, causing massive hemorrhage, and moreover, causing hypothalamic shock of the patient. So please be careful when you treat female patient who is in reproductive age with acute abdominal pain. Never forget to perform pregnancy tests like Sp.P.A. despite of marital status of the patient. It would avoid us from misdiagnosing patient as having acute appendicitis, for example. Here is the gross specimen of fallopian tube where we can find the gestational sac with the fetus inside and also the placenta. Here's the microscopic specimen of our lab work. You have to recognize the fallopian tube with the fimbriae here, ruptured part of the tube wall, and the normal chorionic villi here. Look at the small size of villi that resembling straws. It contrasts to large hydropic villi of Hydatidiform bowl. And here is the fetus outside the fallopian tube. In this microscopic specimen, we can observe the fallopian tube with dilated lumen, filled with blood clot, and we also can find the chorionic villi as a part of placenta. And here we can see the thin tube wall. Here is the higher magnification of chorionic villi that consisted with first trimester to early second trimester pregnancy. We can observe the two-layer trophoblastic cells on the surface of chorionic villi. The inner one is cytotrophoblast, while the outer one is syncytiotrophoblast. This is the blood vessels here, the blood vessel containing nucleated red blood cells. It indicates the fetus formation. In this picture, we can see chorionic villi with the inner cytotrophoblast and the outer syncytiotrophoblast. And within the stroma, we can observe the blood vessel containing nucleated red blood cell. In tubal ectopic pregnancy, we can also find decidualization, just like in a normal intrauterine pregnancy. Here are the decidual cells in the tube wall. In the intrauterine pregnancy, decidua derive from the stromal cells of endometrium that undergo decidualization. Here is the surface epithelium of fallopian tube. Now we move to our fourth topic, female genital tuberculosis. Despite the case is quite rare, we still should pay attention to these cases since it causes infertility. On clinical examination by colposcopy, we can observe irregular erythematous lesion in portio. This lesion microscopically is not specific for any entities, so it may be assumed as malignant process also. In such cases, histopathological examination should be performed to establish definitive diagnosis. Tuberculosis can also affect endometrium and ovary and fallopian tube or adnexa. Here we can see the caseous necrotic material within the uterus. In this lab work, we will have microscopic specimen derived from cervical tissue. In this picture, we can observe the surface epithelium here and the endocervical glands. The glands are covered by simple columnar epithelium. The stroma between endocervical glands contain hemorrhagic area and infiltrated by inflammatory cells, which looks like scattered small dots. In several pieces of tissue on the slide, we can see paler area in the stroma. These paler area are granulomas that consist of epithelioid histiocytes. We can also see Langerhans multinucleated giant cells. We can also appreciate the darker area outside the granuloma that heavily infiltrated by lymphocytes. These darker area appear to enclose the granuloma. At higher magnification, we can appreciate the endocervical tissue with scattered inflammatory cells in the stroma. In this picture, we can observe the chronic inflammatory cells, the plasma cells, and lymphocytes. This paler area in the stroma is granuloma. Epithelioid histiocytes that compose the granuloma have quite abundant cytoplasm. This leads to paler color of granuloma compared to the normal stroma. The nuclei of epithelioid histiocytes are elongated. These cells might coalesce to form a Langerhans multinucleated giant cell. Langerhans giant cell is characterized by the arrangement of nuclei at the cell's edge, partially or fully encircle the cell. Its eosinophilic or pinkish cytoplasm converge at the center of the cell. And the blue dots outside the granuloma are in fact the lymphocytes. This is another granuloma. This is epithelioid histiocyte, or also known as macrophage. The nuclei are elongated, and these are lymphocytes. This is the Langerhans multinucleated giant cell. Please don't be confused with Langerhans cells because they are totally different. The nuclei of Langerhans giant cells are arranged at the edge, encircling the cytoplasm. This porridge-like area is the caseous necrosis of tuberculosis infection. We cannot appreciate any nuclei or distinctive cytoplasmic membrane anymore. This picture also shows caseous necrosis with some necrotic cellular debris. Now, our next topic is endometrial polyp. Endometrial polyp is the most common lesion found in the endometrium. The specimen sent for histopathological examination usually derived from curettage procedure. This picture shows microscopic appearance of endometrial polyp in hysteroscopy. This area shows uterine cavity, and here we can see a polypoid mass that protrudes to the uterine cavity. If such polypoid lesion found in other organs such as endocervix, we can call them endocervical polyp. In this microscopic specimen, we can observe the endometrial tissue with the myometrium below. Here we can see the protruding mass arises from endometrium. This is the endometrial polyp. Normal endometrium and endometrial polyp share similar component, like endometrial gland, here are the glands, and the endometrial stroma, here stroma. So what is the difference between normal endometrium and endometrial polyp? The first thing is endometrial polyp forms a polypoid shape, and its stroma generally looks fibrotic or contain more connective tissue, comparing to the normal endometrial stroma, which is more cellular. There are abundant blue dots. Polyp stroma looks pinkish and forming fascicles-like pattern. It is because they contain more connective tissue. The glands within the polyp have tubular shape, and some of them looks dilated. This shows polypoid structure. Here the polypoid structure. And this shows dilated glands. And here are the small glands. In higher magnification, we can see the glands once again. Some are small and some are dilated, and this is the fibrotic stroma. At the center of polyp tissue, we can find groups of thick-walled blood vessels here. This is the one of endometrial polyp characteristic. This picture shows higher magnification of thick-walled blood vessels. These are the glands, and here are the fibrotic stroma. These three components compose an endometrial polyp. The glands, some are dilated, the fibrotic stroma, and the thick-walled blood vessels around the center. So, this is the last topic of our lab work, Galactocele of the breast. Galactocele is related to lactation process, commonly found in breastfeeding or post-breastfeeding women. In ultrasound, the galactocele appear as cystic mass results from milk accumulation due to mammary gland obstruction. Instead of flowing to the lactiferous duct, breast milk accumulate inside the mammary gland, causing dilatation and forming a cyst subsequently. Galactocele can also arise in women who undergo sudden weaning from breastfeeding. Once a galactocele is formed, it may rupture and then clinically elicits pain. This is the microscopic specimen from an intact galactocele without any rupture. We can appreciate the glandular structure with dilated, elongated, and sometimes anastomosic. It looks enormous compared to the normal mammary glands over here. On the inside, we can see the surface epithelium of mammary gland. These pictures from our lab work microscopic specimen. Here we can observe the secreting mammary glands that producing breast milk. The glands look tortuous. And the left side picture shows ruptured galactocele. This is the breast milk remnants, and this is the cyst wall that have been infiltrated by chronic and acute inflammatory cells. Here are the cyst wall. The inflammatory cells also appear in the cyst lumen. This is a higher magnification picture of secreting mammary glands. The vesicles Inside these cells contain breast milk that would be secreted to the acidae and then to the intralobular ducts and then to interlobular ducts and then finally reach lactiferous duct. This is the obstructed duct. We can see the residual breast milk within the lumen, and because it has ruptured, we can observe the inflammatory cell infiltration surrounding the wall. On higher magnification, this is residual milk. This is the cyst wall with inflammation. Here's the inflammatory cells infiltrate, full of inflammatory cells. This is the macrophages. We can appreciate its Sp.P.A cytoplasm. So we call these cells the Sp.P.A macrophages. These macrophages phagocyte residual breast milk. Okay, this is the end of introductory lecture for anatomical pathology practice. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.